And I am delighted to introduce our panel for this presentation. I have told them I'm just going to introduce by name and title and then turn it over to them for a more in-depth and detailed description of themselves because they are the best ones to do that. So I just want to say thank you to them, and we are delighted to have with us today Regina LaBelle, the Director of the Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown Law, Shelly Weizman, who is the Associate Director, Emily Melvin, who is a third-year medical student at Georgetown, and Kate Gallen, who is a second-year medical student at Georgetown. And I'm going to turn it over to them and mute myself so they can talk about their work. Thank you very much.
Okay, I'm just gonna unmute myself. Hi everyone, thank you so much for joining us. I'm just going to share my screen so you can see what we've got for you. So I'll just introduce myself again. I'm Kate Gallen, a second-year medical student.
And I am Emily Melvin, a third-year medical student, and we're part of the HOYA Dope project.
Yes, so our advisor of our organization is Dr. Eileen Moore, and we'd just like to acknowledge Dr. Adam Visconti from the DC Department of Health. He's the one who comes in and trains our medical student volunteers and also gives us the Narcan that we are able to distribute in the community. So we are here on behalf of the HOYA Dope project, and we're just going to talk a little bit about how we've tried to expand naloxone distribution in DC and as well the importance of opioid use disorder education in medical school. So essentially the first question that we asked is there a demand for naloxone? And as this chart describes, you can see that there's just like a huge increase in the number of prescriptions that went out for naloxone over the last 6 or 7 years as a result of the opioid epidemic. So there's definitely a demand in this day and age for naloxone, and it's been shown that getting it out into the hands of people who are most likely to witness an opioid overdose is one of the most effective ways to combat the opioid epidemic. And here in DC, naloxone is available without a prescription in every ward. So now that we know that there is a demand for naloxone, the next question is, does distributing naloxone work? And this chart shows the results of a study conducted by the Harm Reduction Coalition from 1996 through June of 2014 that shows that they conducted over 600 different trainings and provided over 150,000 kits to 150,000 people, and received reports that over 26,000 overdoses were reversed using Narcan. So this just demonstrates sort of the huge effect that getting Narcan out into the community can have on the opioid epidemic, and that is what our organization tries to do. And so now that we know that there is a demand and that it does work, just to provide sort of the context for our community and see, is this something that we need here in DC? And unfortunately, the answer is yes, very much so. The chart above shows the number of opioid overdose deaths in the district. You can see that in 2018, there were 191 opioid-related deaths, which was actually a decrease from 2017, where there were over 240. But nonetheless, it has skyrocketed in the last 5 years, mostly due to heroin and synthetic opioids such as fentanyl. And 81% of all these deaths were among African Americans, and wards 5, 7, and 8 have the most deaths, with people aged 40 to 69 most affected. So we can see that there's a demand for naloxone. It does work distributing it to people, and it is very much needed here in DC.
So with this background in mind, what we do at the HOYA Dope project is we invite the Department of Health to come in and train our medical students at Georgetown. And so you can see here in the center picture, Dr. Visconti from the Department of Health is training medical students on the pharmacokinetics of naloxone and how to administer it properly. So you can see the the medical students are using dummies and practicing on how to administer the drug. And then these medical students sign up to go out into the community to all of our different partners and train the community on how to use naloxone, or educate the community on how to use naloxone, and distribute the kits that we receive from the Department of Health. And so you can see here some of the icons of our partners. So Thrive DC, Catholic Charities, and the DC Jail are some of the sites that we visit frequently. And in the last year, we've distributed 600 kits to over 350 community members throughout these trainings. And the naloxone that we are distributing is supplied by the Department of Health's Live Long DC campaign. So it's free of charge to us, and then we just distribute that to our community partners.
And so as every facet of society has had to adjust their activities surrounding the pandemic, our organization has also had to. And, you know, we know that the extreme isolation and economic uncertainty of the pandemic are two very prominent risk factors that can cause somebody to have an overdose. And this article from the Washington Post actually shows the very scary, dark reality of the pandemic and its effect on drug overdoses, which have increased over the last several months. So we're very happy that we've been able to kind of shift gears a little bit and conduct 5 virtual trainings or virtual education sessions, and conduct 2 contactless drop-offs of Narcan to community members in DC. So we definitely think now more than ever, this is very important, and we're glad that we've been able to adjust a bit. But we do hope that we can continue doing our hands-on sessions as soon as it's safe to do so.
And another facet of the HOYA Dope Project's work is that we feel really passionate about embedding MAT waiver training and education about substance use disorder into the medical school curriculum, not only at Georgetown, but throughout the US as well. And so we know from our research that this training for medical students is effective. So a recent study that just came out showed that medical students who receive this training in the medical school curriculum report that they're more likely to prescribe buprenorphine actives. So we know it works. And then additionally, we know it's feasible because it is available. So this training is available as an 8-hour online course free of charge to medical students. And so students can take this course as medical students, and their certificate never expires. So then when they become MDs and are applying for their DEA license, then they're able to apply for the X waiver in order to prescribe buprenorphine based on the training that they did as medical students. And so at Georgetown, we are really proud of our administrators for incorporating this training into the required medical school curriculum. And so to date, it's been going on now for 2 years. To date, over 400 students have completed the curriculum. And what it entails is the 8-hour training embedded into a week-long pain and addiction deep dive. And so all of our students then graduate with that MAT waiver training under their belt. And so this year it actually was done in a virtual setting because of the COVID pandemic. And so the 3rd-year medical students were able to complete this course online. And so they are now all, they have that MAT waiver training to take with them to the wards when they are able to return. And that is what we have for you today. So thank you so much for your attention. We have our email address here. We would love to hear from you. Any feedback about our presentation, ideas, or any questions that we can answer. And then we also have at the bottom, we've included a link to the DC Health, Department of Health's Narcan availability website. And so there you can see where you're able to locate Narcan throughout all of the different wards in DC. Thank you so much.
Thank you.
All right, thank you all so much. That was an inspiring presentation, even with the sad numbers that are behind it. So I'll turn it over to Shelly and Regina for next comments.
Thanks very much. And I want to thank Robert and the Medical Society of DC for having us present this evening. And I am just going to share my screen and just have a few slides to go over. First, as Robert said, we work at the O'Neill Institute at Georgetown Law Center. And our Addiction and Public Policy Initiative has been in place since November of 2018. And our goal is to advance evidence-based treatment policies for people with opioid use disorder and substance use disorder generally. And we have a variety of initiatives. We're funded through Arnold Ventures primarily. We have issued a report on advancing the evidence report last year. And we also have a summer series where we're diving deep into medication-based treatment in correctional settings. The reason we've focused so much on individuals in correctional settings with opioid use disorder is that the research shows that some of the most at-risk people for overdose death are people who are re-entering the community from the criminal justice system. So that's an area that has a really good law and health nexus, so that's why we focused on that. We also have a recovery policy collaborative headed up by Shelly Weizman, and she'll discuss that. One of the basic premises of our work is that we involve and engage the voices of individuals with lived experience throughout all of our processes. So that means people who may have had a criminal justice background, but also people who are in recovery from a substance use disorder. We've collaborated with the National Governors Association, the Department of Justice, and then lastly, I'll talk today about a new master's program that we're going to start at Georgetown that we're very excited about. So today, I want to start by talking about the interplay between the opioid epidemic and COVID. Briefly, and talk briefly about some of the laws and regulations that have been revised under the opioid public health, the public health emergency for COVID, and talk about DC briefly, and then update on some of the work that we're doing. So the federal government actually responded very quickly in light of COVID in March because of, as many of you are aware, there is a multitude of federal regulations around treatment for opioid use disorder specifically. Because of the 3 medications that are FDA approved to treat opioid use disorder, they are controlled substances. So methadone in particular and buprenorphine have an array of requirements. So it's not just the Food and Drug Administration, it's not just the Drug Enforcement Administration, it's also HHS. So that multitude of laws and regulations, some of them have been changed in this time of crisis. And one of the reasons I believe the federal government did this, one was because we're currently under a public health emergency for opioids. That continues to this day. And actually it's up for renewal this week. But at the same time, I know that there was an awareness of what happened in the wake of Hurricane Katrina and Sandy. There were many people who were unable to obtain their life-saving medications because of the rules that attach to methadone and buprenorphine. So because of that, and that it's already hard to get treatment for opioid use disorder and evidence-based treatment for substance use disorders generally, but public health emergencies make it even harder. So the federal government actually did a good job with revising regulations around telehealth, starting people on buprenorphine, allowing more individuals to take home methadone so that they did not have to go, especially if they're in the early stages of their treatment, they didn't have to go to the clinic on an almost daily basis to get their methadone. They can have take-home doses with some parameters, but it allows for more take-home doses for people. And if we think about this, so again, so there are 2 million people with opioid use disorder in this country, and about 70% of them don't receive any type of treatment. And so the goal right now is not to make it any worse than it was already. So we need to make sure we're retaining people in treatment who are getting treatment, and making sure that we're getting the harm reduction services like naloxone to people so that overdose deaths don't go up. And I'll talk a little bit about that in a minute. But there have been some interesting innovations that have happened at this time. In Massachusetts, almost 3/4 of methadone patients have some level of take-home now. So they've had less than 30 incidents of a lost, stolen, or diverted medication. And that's with between 13,000 and 17,000 patients. Rhode Island also, this is interesting, they're experimenting with a buprenorphine access line that would allow, so it's a hotline where people can access it 24/7. There's an initial assessment, and you can be referred for buprenorphine treatment right away. And again, we make it harder for people to get treated for the opioid use disorder than we do to get the opioid itself. And so this low barrier buprenorphine of one of the 3 forms of medications is an innovation that we're seeing right now. More states are allowing for this to happen. So as I said, so if we think about, 70% of people who are not receiving treatment for opioid use disorder, there are a few gaps that remain. And the gaps that remain really are around harm reduction services. So there was a survey that went out in April of syringe services programs in the United States. And the survey was about what the effect of COVID-19 was on these services. And they found a 43% of the people who responded, the syringe services programs that responded, so 43% reduction in services. Now there's a number of reasons that could occur because of lack of the ability to social distance, the lack of protective equipment. And in some states, syringe services programs are considered when we had the total shutdowns in the first stage of COVID-19 shutdowns, they were considered essential services in some states. But accompanying that essential service requirement, there weren't any additional funds. So in the early stages, we saw this reduction in services, and that's quite serious for people who rely on syringe services programs to obtain, if they continue with injection drug use, they need sterile syringes. And so this is a big gap that we've seen around the country. The second big gap, and again, it's important to remember that along with COVID-19 has come this increase in infection rates in a lot of institutional settings, not to mention what's happened in jails and prisons. And so reentry services are critically important to providing people with the services they need under normal conditions. But when the safety net is reduced in a time as today, and so what we've seen around the country is that almost 70% of reentry services have been reduced or ended in their entirety. And the survey done by the Council of State Governments showed several different reasons for this, a multitude of reasons for this, some social distancing, but also financial concerns were a big issue. And we remain concerned about the instability and the unstable sources of funding that we will see going into economic downturns. We already know that states, and I don't think DC is any exception, is going to be seeing reductions in revenue next year. And the budgets that are being produced now by these states reflect that. And so the services for people most at risk for overdose, the reentry population, or most at risk for other harms, including people who are who inject drugs, those services, when they are reduced, will have a very serious effect on overdose death rates as well as other infectious disease. So what we're seeing around the country right now, and this is DC, and I'll get to that in a second, we've heard about spikes in overdose deaths. Now, we're hearing about spikes in overdoses and overdose deaths. A lot of the media that's covering this is not distinguishing between overdose deaths and overdoses. They're both very serious, but I think it's important that we remember that we don't really know what's going on right now because there is no national data set that will tell us right now. So one of the pieces that in media that's come out in the last couple of weeks relies upon kind of it's a good sample, but it's a self-reported sample of overdoses and overdose deaths around the country. And so it's indicative. I think it's important also to remember though, that we were on the upswing in 2019. So the National Center for Vital Statistics will show that that overdose deaths for 2019 were increasing. We also saw an increase in fentanyl-involved overdose deaths. And again, DC is, so when we're thinking about what's going on, we can't wait for the researchers, but there is a lot of research that is being conducted right now. So we can see, is it because people are using alone? Then we need more naloxone on the street. Is it because there's a shift in drug markets? And so that can affect this. The social isolation could be causing a return to use. People's, if they have an opioid use disorder and they haven't used in a while and they may not be on a medication, they may be more likely to overdose. So we simply don't know what's going on, but we do know that we have a very unstable treatment system. We need increased amount of harm reduction services around the country, and funding needs to be a priority for these services. So this is a chart from the Office of the Medical Examiner in DC. And I know previously our colleagues with the HOYA Dope project showed what's happened in the District of Columbia. And I thought it was good to see. So the latest data that we have is January, February, March. So March, January was the first time of a reported COVID case, but really mid-March, March 10th was when we did the shutdowns. So we are seeing an uptick over last year. The other, I think, really important piece is that there's been an uptick in undomiciled, so people experiencing homelessness who are overdosing. And, they are most at risk. They're at risk for contracting COVID. They are at risk for other illnesses as well, and overdose is no exception. So I think DC last year, so 2019 data showed that there were 44 undomiciled people who died of a drug overdose. And this year there are about 19. So we're on pace to surpass last year's number. So there's, as I said, there's a lot of research that's being done. We can't really, again, we can't wait months for this research. We do know what needs to be done. Fortunately, the changes, the regulatory and legal changes that have been made at the federal level and state level have, I think, resulted in people having more retention and treatment of that 30%. I'm saying that because I'm hearing that anecdotally, but we'll know that in a bit. So I also want to briefly touch on a new project that we're doing at Georgetown. In July of 2021, there will be a Master's in Addiction Policy and Practice program that will be housed in Georgetown's School of Arts and Sciences, but it will be an interdisciplinary one-year master's program. More information will be forthcoming on that, but the purpose of that is to build a cadre of policy professionals who can marry the science with law and policies so that we can really move the ball forward on having a more evidence-based approach to addiction. And I think our colleagues from the HOYA Dope Project are a great example of how not only the commitment of Georgetown, but the commitment of institutions such as the medical school to really move the ball on these issues. So thank you very much, Robert. And now I will turn this over to Shelly.
Great, thank you so much, Regina. I think kind of building off of what Regina was talking about with this new federal flexibility related to the rules for accessing certain medications, for accessing services, relaxation of telehealth. I think this highlights a couple of things. One is that there have been some barriers to care and rigidity that has existed in the system for a long time. And the COVID crisis has been an opportunity to take a look, a hard look at some of those kind of structures and frameworks and determine whether or not they should remain. And there's some research going on right now in a number of institutions that are looking at, what is the impact of these relaxed federal rules. But, I think it's kind of part of a theme of what we're seeing that governments are moving towards and the provider community and the recovery community is moving towards, which is a much more kind of nimble and flexible system. What might be good for one patient might be a barrier for another. And what Regina discussed about state governments and the federal government likely as well, in the next, very soon, we're going to start to see the impact of the COVID response on state, local, and federal budgets. And systems that were already kind of teetering on the brink, living, paycheck to paycheck, small community-based organizations and even large organizations, there is going to be, I think, some serious challenges ahead. And this highlights even more than ever that the response to addiction treatment and recovery support services really need to be weaved into the mainstream health and social services system. And we talk a lot about that. We talk about upstream interventions. We talk about, addressing addiction through screening and referral. But I think now is the time to really fold it into, along with mental health services as well, everything we're doing at every level. It's really going to be an all hands on deck type of scenario. And the work that is happening at the medical school at Georgetown, the work that's happening with outreach to physicians and PAs and nurse practitioners who can prescribe buprenorphine. All of these efforts are critical because, again, there are not enough kind of boutique providers to do this work. Again, these upstream issues, we talk about the social determinants of health, right? Housing, stability, employment, social supports. So personally, I'm a person in long-term recovery, and I'm seeing a lot of people who, are new to recovery and having to navigate access to treatment in the COVID crisis. And some people are actually thriving in that type of an environment with, access to 12-step meetings on Zoom 24 hours a day, or, working with their provider who's able to see for the first time, what their living situation actually is and help them address it. Others, I think, are really struggling with the social isolation that Regina talked about, the lack of connection. We know that kind of the secret sauce to recovery is connection and purpose and, you know, really building a life. Yes, we can have stability and medication and treatment, but, you know, I have a colleague who used to say a home, a job, and a date on the weekend. And that's true for all of us, right? In and out of recovery. And, you know, I think what this is really reflecting is that it's not a one size fits all, that we need to have every avenue available to the people that need it right when they need it, to make it easier to access treatment and recovery supports than it is to go out and use. And it's really easy to go out and use. So we really have a long way to go to make it really easy to get help. And I think that starts with identifying and removing some of the barriers that, you know, exist, maybe because that's just the way we've always done things, or it could be, you know, law and policy barriers. Things like, you know, potentially unnecessary urinalysis screens or in-person visits when it could be made over the phone if someone has a transportation problem. You know, different people get engaged in different ways. Some people might get help from their doctor. Another person might get help from their pastor or their church community. And, you know, all of these systems, we need a dynamic range of services and access to evidence-based treatment where, you know, we're really utilizing every aspect of the community at our disposal. And, you know, I think the point that Regina was making and the data that we saw is we need to have an understanding of what's going on out there in order to be able to respond effectively. You know, there's a lot of anecdotal information. Is it overdoses due to recreational use and the need for a safer drug supply? Is it related to increased alcohol use? We're seeing an increase of alcohol sales. So, you know, I think getting to the root of the data, understanding what's going on, and then understanding that it's a comprehensive problem that needs every part of our systems to address and support. You know, tethered to things like loneliness, economic mobility, social mobility, right? People, you know, want to be able to live and be a person in the world and not just tied every day to medical appointments or treatment, you know, indefinitely, right? So now could be a total opportune time to take a hard look at our systems and do what needs to be done to change them. And, you know, a note about the project that we're working on, which is called the Recovery Policy Collaborative. It's a network of policy professionals in recovery. So this is people who are in and out of government. So I've been in, you know, worked in state government, you know, in advocacy, in all of these different places where, you know, you start to accumulate subject matter expertise. And there are, you know, and you marry that with your personal lived experience and what you've seen out there navigating the system. And there are a lot of people out there who, you know, are doing this work from a place of lived experience. And, you know, what we're seeking to do is kind of put all of our collective heads together and start to reimagine our systems, how our systems are funded, what are the incentives, are there misaligned incentives, and how do we do it differently, to collaborate, to mentor others, and hopefully to, you know, launch some projects where we really can build on the collective good work that's happened and take it to the next level. So we're really excited about that project as well. And that's it for me.
Great. Well, I will take the floor and first of all say, again, thank you to our four presenters, not only for being here and talking about this, but for all the good work that you're doing on a very important topic. So I would be remiss if I didn't thank you all for that. I'm going to remind our folks on the meeting to feel free to ask questions. You all are not a shy bunch. I know this because I recognize your names. And I know there's not a shy one among you, but feel free to drop some questions in the chat box. I have some questions, though, that I want to ask to get started with. Most of these are for all four of you, for our presenters, but I'm going to start with the specific ones. First, for Regina and Shelly, you all talked a lot about some of the changes that have been made during the public health emergency, things like expansion of telemedicine or televisits, flexibility in terms of treatment options. One of the things that we're concerned about with the medical society from a medical perspective is we are still in the middle of a public health situation, but a lot of these public health flexibilities may be going away due to government concerns. What happens if these flexibilities that you all talked about either get taken away, waived, or reduced in some way?
So I think, as Shelly was saying, this is a natural kind of pilot that we're undergoing right now. And I think there are people who are looking at, who are very interested in making these changes, at least many of them, permanent. So what would that take? Some take federal action, some take state action. And there is legislation pending. I think the one that has the most traction right now, because it applies across the board in addiction, not just to addiction, is telehealth. And there's legislation specifically regarding that's been introduced by Senator Portman and I think Senator Whitehouse. So bipartisan legislation. So there is a great deal of interest. What would happen? I think that it would be a real setback if we were to put everything back the way it were. And I think it's important to remember that we're still under an opioid public health emergency. So if these things could happen under a COVID emergency, they can happen under an opioid emergency.
I think, what I've heard, the phrases that you can't unbake the cake, right? With some of these, particularly telehealth, flexibility, that we're really seeing an explosion of access in rural areas, in areas where people struggle to find transportation, and it just makes it, much more seamless to access services and to provide services for a lot of providers. So I think we're going to see in the coming months the fruits of some of the research that's going on right now. I know the CDC just put out a nationwide survey for X-waiver who can prescribe buprenorphine prescribers to gather information about what the impact has been on the providers and patients. And there are other projects going on in a number of states to try to understand what is the impact of this flexibility. And I think what we're hearing is decision makers in the federal government are trying to understand what the impact is in order to act accordingly.
Great, thank you. I also would be remiss if I did not mention that MSDC does offer a physician health program for those physicians who are struggling with addiction and maintaining their license. So shame on me for not mentioning that at the beginning. I know our chair would be very unhappy with me, but I did want to put that plug in now. Speaking of chairs, the chair of our Public Health Committee, Dr. Sam Cariff, is following up on my question with another one to anyone who'd like to answer. In addition to telemedicine, what policy solutions would any of you like to see enacted locally to address the problems we've discussed?
Well, one thing that we're actually looking at is that the naloxone access and training law could be revised so that it's easier for people like HOYA Dope to train trainers. And we know, as has been said, that you need to saturate a community with naloxone. So there's no reason for it to be harder to get out. And so the naloxone law in DC has some restrictions that should be looked at. I mean, that's one very specific area. I think that the other issue is, and I'm just going to you know, I don't want to dominate this, but I feel really strongly about the issue of stigma. And, you know, DC is small enough that, you know, we could address, we could talk about this more openly. You know, one of the reasons we make sure to involve people with lived experience is not only because they're an important piece of any policy solution, but because it's really important that we get rid of that stigma. And I think I would like to see, yeah, I think that's something DC could do, is as a community, discuss it and discuss the issues of substance use disorder more openly.
And I'll just add, I think DC is also a place where we can really address the pervasive health disparities that we see in access to treatment among the racial disparities, right? There have been studies that show people who are white get access to buprenorphine at much, much higher rates than people of color. And, you know, DC, there are, you know, this plays out in a number of different areas in general healthcare, and addiction treatment is no exception. So I think, you know, that is definitely an area that can be focused on, and engaging the faith community, engaging, you know, kind of the all hands on deck type of approach. And I know that Dr. Chapman, who's listening and on the call, has been a huge leader in that area, but there's still a long way to go. And, you know, I think, again, this idea of seamless access to treatment, and it doesn't even have to be treatment, just the help that somebody needs right when they need it. We know that when somebody is ready to get help, there is a window of willingness, and that window closes fast. And we need to make sure that people can get the right help right when they're ready.
Just to go off of the stigma piece a little bit, I mean, I'm not well versed in the policy world, so, but, you know, just from our personal experience of going into these different areas of the community and doing these education sessions, if we talk to somebody about getting involved in somebody who's actively having an opioid overdose, people are very hesitant. They're hesitant to use naloxone. They're worried about their own sort of protection and everything. And a useful analogy that I've found is comparing it to an EpiPen, which most people are familiar with. You know, it's a life-saving intervention for somebody who is in anaphylactic shock from an allergy. And they're like, oh yeah, I would definitely do that. And then I'm just like, you know, think about naloxone just like that. It's a potentially life-saving intervention for a person. And then you can kind of see that there's a sort of shift, that cognitive shift, because I think that the stigma sort of is responsible for some of that hesitation. But then when we kind of compare it to something that doesn't have as much of a stigma and see the commonalities, that people are much more willing to kind of change their perspective.
I would add one more thing on a wish list of policy changes that might happen in this area. We talked about it a little bit, but incorporating this training in medical education, I think, is really important. So Georgetown is one of very few medical schools that offers this at this time. And I think it's really important that this, you know, what we're doing, the word gets out. And so even if it's just by like academic peer pressure, medical schools should be offering this across the board.
Can I just say that when it comes to addressing stigma, medical schools incorporating this training is one, you know, total concrete example of how we can really start to kind of normalize and address this issue, that it's not, you know, this other issue that you have to go over there for, that everybody can help. So I think, you know, sometimes when we think about stigma, we think about public service campaigns, you know, things like that. But incorporating it into medical training and clinical training it might be the single kind of biggest thing that we can do.
Great, thank you. Emily and Kate answered 3 of my questions I had for them just now. So thank you for that. We have a question in the chat, but I want to go to Dr. Chapman, who has his hand raised. So Dr. Chapman, the floor is yours if you don't mind unmuting yourself.
Hi, glad to be on this call, and thank you for doing this, Robert. This is such an important topic, and especially when I started opioid treatment, I was very naive at the importance of advocacy and the fact that you have to, because the patient population will not advocate for themselves, and physicians were reluctant to treat this population because of stigma, the law becomes extremely important in advocating for this patient population. And I think the O'Neill Institute is unique in their background and understanding of the importance all around, from criminal justice, from social service, as well as healthcare, and tying all the pieces together. It's a very complex problem, but I think we have a very unique opportunity having the O'Neill Institute to take this on.
Couldn't agree more. Thank you, Dr. Chapman, as always. Question from Dr. Bullock I want to ask, because this ties into a couple of different issues that are prevalent in the district. What effective policies are out there with regards to pregnant women where they require particularly different supports and access issues come into play? So pregnant women, whoever would like to go first.
So, so pregnant women with opioid use disorder, we know that, you know, they can respond well to medications during treatment. And again, I know I'm talking to a bunch of doctors, and I will not put on any type of pretend clinical hat. But from the research I've seen, that's true. But we also know that I think on a policy level, we have treated often the parent separately from the child. For pregnant women, so postpartum women have among the highest rates of overdose death. And part of that is because they don't get treatment while they are pregnant. And when they leave, they go back to using at the same level, and so they overdose. We also, so there are policies that have been put into place that are, so the Family First Preservation Act was passed by Congress in 2018. And the point of that act is to combine services between social services and substance use to prevent foster care placements. Because what we've seen is an increase in foster care placements over the last several years because of substance use. They don't really parse it out between addiction and between alcohol and drugs, but it's primarily because of opioid use. So I know that there are, you know, policies that are going to be implemented. I don't think that will keep families together, and that treat the family as a family as opposed to the child here and the parent here. And one of the biggest issues, policy issues we could do is to make sure that women who may be using drugs are treated with respect and trauma informed, because they will be much less likely to get prenatal care that they need if they are going to be arrested, which is the case in some cases, for child abuse. And so there's a lot of work that needs to be done in this area. I think that some federal funding is going to that. I think states are kind of figuring it out as we go along. It's a real open field right now.
Yeah, I'll just add, I think it's a really important question, you know, and the child welfare system, the criminal justice system, shelter system, these are all kind of systems that operate outside of treatment and healthcare, and, you know, have come a ways to embracing integrated kind of access to treatment. But in some areas of the country have a ways to go. And I think what we're seeing that is successful around the country are systems. That means from the state legislature to, you know, child welfare, treatment, hospitals on down, that really take an approach that they want to keep families intact, and do what it takes to have wraparound services for pregnant women and postpartum, programs that allow the mother to stay with her child, and that have a communication structure with the provider or the hospital, and the child welfare system or worker. I think sometimes the challenge in the past has been a lack of communication, and kind of operating on parallel tracks. But where we're seeing success is where there's kind of a cohesive approach. The other thing I think that we're hearing is that and this isn't specific to pregnant women, but it's specific to families, is that there's a real need for increased services that address the family as a whole. That if it's a treatment program treating a father, that it's a rare program where the child can stay with the father. I mean, it's rare already where the child can stay with the mother, but even more rare for a program that's father-child or father-baby. So again, really thinking in a nimble and dynamic way that's person-centered, trauma-informed, is where we're seeing some success. But this is definitely an area where there's a ways to go. I mean, there are some states that are really regressing, terminating parental rights after 6 months, and, you know, again, creating a lot of extra hoops for people to jump through when access to help should be something that's easy.
All right, we are approaching the end of our hour, so I'm going to take the privilege of having the last question, and I'm going to split it in half. Same question, different focus. I'm going to start with Emily and Kate. So on this call right now, you have the presidents of two medical societies. Dr. Pineda has joined us, who's the president for MSDC, and then Dr. Williams, who's the president of MedChi DC, as well as a number of influential physicians who are hearing this live and will be hearing this as a recording. How can the physician community help the HOYA Dope program?
Emily, I'll let you go first since I took the last one first.
Sure. That's an awesome question. I think that from our perspective, we're really lucky to have Dr. Moore from Georgetown as our advisor, and Dr. Visconti from the DOH, but as guidance in this whole project. But we've learned so much from them, and to learn from experiences of other physicians who are treating patients and treating patients with success, I think is something that we could really benefit from, not only as leaders of the HOYA Dope project, but also the whole, the medical student body as a whole. And something that we are thinking about is that doesn't exist yet, but is a fourth-year elective in pain and addiction. And so that's something, like, if that's something that anyone on this call is interested in, something that we are hoping to leave as a legacy, and something that we're starting to think about on our end.
And sort of from a logistical side of things for our mission, I think that the most effective partnerships with community partners are ones that, you know, we've gathered from a connection here, who knows a person there. And so if anybody has any great ideas for people that we can engage to make sure that what we're doing is, you know, we're trying to basically spread our impact as far as we can. And so the more community partners that we can engage with, the better. And so the ones that we've collected have sort of just been either through happenstance or good luck or a talk that we did. And so just getting the word out and getting us into contact with more people that we can have an impact on is always welcome.
Great, thank you. And then for Regina and Shelly, similar question. What can medical organizations or groups of physicians do to help with everything you've outlined today?
Go ahead, Shelly.
I mean, I think one concrete thing is to get an X waiver, be able to prescribe the medication, buprenorphine or Suboxone. And I think another thing we're seeing is groups of physicians, some who are more experienced prescribers, doing learning collaboratives to bring in other physicians and prescribers to help. Again, you know, I think it's going to be an all hands on deck approach. And we're seeing some really good models where primary care physicians can connect with a specialist right then and there, or in an echo model or other models. So, you know, taking on some patients and mentoring others in a collaborative. I think that's one concrete thing, absolutely, that can be done.
Yeah, I think that's great because we don't have enough buprenorphine prescribers. We don't have enough methadone clinics, and actually we have them. They're just kind of clustered, and they're not where they need to be. And that's something that telehealth would help with. But I think that there are physicians when in surveys who say, you know, I don't really want those people in my office, people with addiction. And you know, we all come into contact with people with substance use disorders every single day, many of whom are patients. And so, you know, if you get an X waiver, it doesn't mean you have to, you know, go into that specialty. It just means you're treating your patients. And so that's a critically important piece of the puzzle that everyone could take on. Thanks.
Great. Well, thank all four of you again, not only for being here and spending valuable time with us, but for what you're doing to make the district and the world a better place. We had a comment in the chat box. Thank you for all your thoughts. It would not be a Georgetown session without someone putting HOYA Saxa in the chat box. So we have the necessary HOYA Saxa in there. Thank you, Dr. Kara, for that. But thank you all for your time and energy. Thank you to everybody who participated today. And I suspect this will not be the last conversation we have. So everyone have a good, safe evening.
Thank you very much.
Thank you.
Thank you.